about to experience Healthline, a show where doctors from 𝗂𝗶𝗁𝗃 interact with you for a healthy, uplifting lifestyle. Moderated by Nicole Jacinto. You've got questions, we've got answers. So welcome to Healthline.
Oh, okay. I did not unmute myself. So anyway, hi everybody and welcome to Healthline with 𝗂𝗶𝗁𝗃. I'm your host, Nicole Jacinto. And it's September 4, Monday here in Manila. It's 5 p.m. in the afternoon. And we're going to start the show off by saying hello to, just a general greeting to all the birthday celebrants in September. There's a lot of you listed here. And I know I said I just give you a general hello because today's topic, I think we need to spend some time on it. And with us today, we have Dr. Charm Bernardo. Good afternoon, Dr. Charm.
Hi, good afternoon.
How are you?
Nice to see you again. Yeah,
Yes.
it's been a long time.
It's been a long time, yes. Okay.
Yeah.
Today we're going to talk about depression. The topic for today is depression. And we'll talk about certain things and probably some new treatments or medications that have come along that they use to treat depression nowadays. And we'll get into that a little bit later. But first of all, Dr. Bernardo, thank you for taking the time to come on the show today, to accept the invitation, and to discuss this topic again. It's good for me. It's good to see you after all these years. May not be in person, but this is enough. And I'd like to thank you. You've always given us great insights all the times that you've been on the show with us. And today, I'm sure will be no different. So for those of you who are out there viewing and listening live, do give us your questions live during the show so that we can get the answers straight to you. Dr. Charm can answer you directly. Dr. Charm, so the topic is depression. Can we talk a little bit about, first of all, let's start by defining what depression is.
Okay. Yeah. Depression is, of course, this is a common, thing that happens to everybody. Like, for example, if a favorite pet dies, of course, everybody will feel sad. Everybody will feel depressed. So the thing is, in normal individuals, after 3 or 4 days, you actually bounce back again. And life goes on, you move on and everything, you're still functioning, you're able to cope with everything that's happening. With depression, it's very different. When we say it's a disorder, your functioning is already affected. So you're not able to eat, you're not able to sleep, maybe you don't want to go to work, you don't want to go to school, your grades are going down, your interpersonal relations suffer. So that in itself, it encompasses depression. Depression is kind of different from sadness. Sadness is what we feel, when something bad happens to us. But it becomes depression when, and it becomes a disorder when the functioning is already affected. And it lasts for like 2 weeks. Yes.
2 weeks or more, yes. Thank you, doctor. Okay, so first things first, everyone does feel sad, or they may get depressed. We use the word a lot, and so let's just yes, they get depressed, and there are things that can cause it. There's it may be part of a stage of mourning, if it's mourning, or the feeling loss of a loved one, or loss of an opportunity, something.
Yeah.
And but it becomes a disorder when it lasts for 2 or more weeks and it affects the ability of
The
a person
functioning.
to
To
function.
function. Yeah. Very important. When you mentioned the loss of a loved one, of course, that's grieving,
Yes.
But after a certain period of time, we have what we call pathological grieving. So, so it could extend. So again, it depends upon the timing. But of course, when, of course, a loved one dies, you will feel sad, you will feel, in a way, depressed. But the thing is, after that period, you're able to bounce back. Life resumes, life goes on. There is a void, because of the space that the person left. But still, you're able to do what you need to do in order to survive, in order to live. Yeah.
Okay. So just to make it even clearer, the void can be forever. Can it? But what we're talking about here is the ability to function. When you say life goes on, you mean the ability also to function in maybe the way you functioned before, or maybe not exactly 100% the way you function.
But hey, I need to eat. I need to
Yes,
bathe myself.
exactly.
I need, self-care.
Yeah.
I need to take care of myself. So that's the whole point of it. Yeah, you're still able to do
Yes.
those things. Yeah.
Function like I need to eat, I need to sleep, I
Yes.
need to work.
I need to earn, so
Yes.
that I can survive. I have other people maybe that depend on me.
Yes.
I have my pets, I have my cat. Somebody has to take care of them. So you're still able to attend to those things. Yeah.
Yes. For some people it does get to the point where you just cannot, or you are doing
Mm-hmm.
those things at such a um slow and just a rate that's not enough to be able to say that you are living your own normalcy, no?
Correct. Yes.
Yeah, okay.
Mm-hmm.
Thank you,
Yeah.
doctor. Just to make that clear, because um sometimes we get a lot of pressure or ideas about what may be normal for some, what's
Mm-hmm.
normal for everyone, and some people say, well, this is normal for me, but you're making it clear now. I'm glad you said that, so I asked you that. It's about like, hey, I need to eat, I need to shower, or whatever, I need to feed
Mm-hmm.
myself, feed others. Like,
Yeah.
I will feel sad, I will have my moments, but you just sort of can't move anymore
Correct.
when
Yeah.
right,
Mm-hmm.
doctor. So, what are the usual symptoms of depression?
Yeah, we actually, well, for psychiatry, it's not like when the patient would sit in front of us and then after
Yeah.
just a few words we'd say, you're depressed. No, we don't
Yeah.
do that. Okay, so we have certain criteria that we fulfill in order for us to say that you're depressed. Well, we have two major criteria. This is we have researchers, and these researchers found out that, hey, these are the criteria for depression, and those are the criteria that we follow. Of course, this is Western.
Yes.
We could wish for all we want that Sana we have something that's equivalent for Asians, but this is like Western literature. They're the ones who are very, very good at research and researching this stuff. So number one would be, of course, a depressed mood. You feel lonely, you feel sad, you feel blue, you feel down in the dumps. Usually that is the thing that they tell us. Here it's an or, not an and. Or you have lost interest in anything that brings you pleasure before. For example, before your simple pleasure is going to the mall and just
Mhm.
window shopping. But now, even if somebody would bring you to the mall, you don't want to. It's just that you're not interested in it anymore. So those are the two major criteria, and it's an or. It's not an and, because there are certain clients that would come to me and would say, "Doctor, I'm not feeling depressed. It's just that I'm not interested in things anymore." Still, that could be a depression. You know why? Because the mood for depression and that the interest in things that you find pleasurable actually affects two different parts of the brain. So a patient could come in and say, I'm feeling okay, but if they're not feeling they've lost interest in things, so still that could be labeled a depression. Of course, other symptoms that would come with that is the sleeping, either
Mhm.
sleeping too much or sleeping too little. Of course,
Mhm.
the appetite, eating too much and eating too little. They feel restless. They just get, they don't know where to go. They don't know that feeling. Another is that they're too tired. They're lethargic. They would tell me, "Doctor, I'm actually dragging myself out of bed, and this is after 12 hours of sleep." That kind of thing. Of course, others would feel, it's all my fault. This is hopeless. I feel so hope this is not going to work. It's very negative. Of course, concentration is another problem. They have difficulty concentrating. When you ask them, they would actually tell you, "Can you repeat it again? Because I just didn't get it." So they're just staring blankly into space or something, or maybe just suddenly crying out of, without any reason at all. And of course, of laugh. And the most important for me is actually any thoughts of death. They would say that maybe it's best if I'm not here anymore, or any actual attempt, so to harm themselves. And this is in vogue right now. This is very common, what I hear. It's like, "Doctor, I don't want to hurt myself, that I just want to disappear."
Yes.
And when you say, "What do you mean?" I just want to disappear. I just want to not exist anymore. So that could be an equivalent of, wanting to having those thoughts. Maybe it's best if I'm dead, my family will be happier if I'm not here anymore. So those are the criteria, the symptoms of depression.
So a
Yeah.
lot of things also I'm hearing, doctor, picking up on what you're saying, is that there's a lot of guilt associated with these feelings of depression. And normally
Mhm.
in a lot of people who are depressed, who are there's this cycle of, I've lost interest in this. I think there's something wrong with myself, or I'm not pleasing others, or I'm sad and I can't do these things. And then there's also the I can't function, and maybe paralyzed with fear, or
Yeah, or not really that, but rather they're withdrawn. They don't want to, they just want to stay in the room all day in bed. They're not sleeping, but their eyes are open, but they're just there. They're under the sheets. They don't want to talk to anybody. If before the loved one would be like, hey, let's go out for dinner. And here it's like, just go, just leave me alone. I don't want to associate with anybody. So that could be actually also a symptom of depression. So those kinds of things. So any changes in the behavior of your loved one, of course, it's already a flag. So better if we're able to address it. Yeah.
And there are feelings of guilt, meaning like it's better if I don't exist. Is not only because stopping their own pain, but the idea or being aware that they're not good enough for others.
Correct. Yes. Yeah. That is so right. And they would tell me they would tell me, maybe my family lost the business because of me. I wasn't working enough, but the family members would be, she's actually the one who's there until 12 midnight, but for them, it's no, it's wrong. It's me. It's all me. So blame me, that kind of thing. Yeah.
Thank you, doctor. And that rounds out and enlightens a lot of people about what depression is, and or some of the symptoms that people can exhibit when they have depression. And apart from these symptoms, let's go first to what factors can contribute to someone being depressed. I know you maybe mentioned some of them, but could we go through that again?
Yes. First, two things actually would already jump out. Number one is what we call nature. Another is we call nurture. Okay. Nature is the genes. Unfortunately, we cannot do anything about it. If your great grandmother had depression before, so it could be that gene is passed on to the next generation until the present generation. So that's it, So that is what we call nature. But when I was training abroad in the States, when I would have patients, my patients would actually tell me, Doctor, I'm diagnosed with depression, but my whole family doesn't have depression, or the whole family is depressed, but I don't have depression.
Yes.
So it means that it's not 100% genes. It's not 100% genetics. So here comes the concept of what we call nurture, which is the environment. So the environment could be very toxic. It could be filled with trauma. It could be very violent. It could be very chaotic. So in a sense, you have the gene, and then here comes nurture, your environment. It's so chaotic. So it's like creating the perfect storm. So most probably the depression will come out. So those are the things that we are considering. So it's mostly a combination of nature and nurture. Okay. But as you can see, it's also not 100% nurture. Why? Because there are some patients that are, in a violent relationship maybe, or in a violent environment, but still would not have the expression of depression. It could be other disorders, but not depression. But still, so it's more of a combination of the two. Those are the two most important. Number three, especially for women, would be hormonal. So I would have patients who would tell me, Doctor, so they would say. So I would, of course, I need to ask. So I would tell them the symptoms of depression. Maybe irritability, maybe, feeling so guilty, maybe just staying in bed the whole time, nothing, no impetus to move, not being so active, just wanting to stay in one place and feel there. It's just there. So I would ask them, does this happen, or does this get more worse just 1 week before your period? And then they would start to think, oh yeah, doctor, you have a point. So again, number three, especially for women, would be a hormonal component to it. So if it's like that, usually I would tell them, hey, why don't you get checked by your OBGYN to see if there's any factors there that would lead. And at the same time, I myself would adjust my medications. So those are the top three. Of course, number four would be trauma, extreme trauma you're exposed to, and those kinds of things. Yeah. So those are some of the factors. Yeah.
Some of the factors. Okay, thank you, doctor. Perhaps we can get get into that because you're talking about, okay, nature versus nurture and some of the factors. When it comes to diagnosing depression, how do medical professionals do this, and what do you define as a medical professional? Because we have psychologists and who do not get a medical degree, but they're trained in being therapists for people who have depression, who need therapy and all of that. And there are psychiatrists like yourself. Okay, so let's start there.
Okay, yeah. Well, that's a very good question. Okay, now, what can I say? I will try to be very politically correct here. Okay, yeah.
Don't have to.
So, no, I have to. Okay. Now, the thing is, of course, for a diagnosis of depression to be given, it should be done by a mental health professional, doctor, because doctors are the ones who diagnose. Because when we diagnose, if we have to prescribe treatment, it will come from us. Yes. It will not come from any other specialty. So it is the job of the doctor to give the correct diagnosis. So to diagnose the patient, because the doctor is the one who will be evaluating the patient, So through the history, asking the right questions, we are the ones who are eliminating, while we're talking to the patient, eliminating already certain psychiatric conditions in mind, so that we reach a point wherein we diagnose the patient with depression. And we just don't pull it out of the air. We have what we call the DSM-5, the Diagnostic and Statistical Manual. This is done by the American Psychiatric Association. They're the ones who gave the criteria, and that is the one that we follow. Okay. Now, there are some psychologists, and fortunately enough, the psychologists that I have encountered actually would tell the patients, I think you have depression. Why don't you go to a psychiatrist to be diagnosed?
Yes.
Yes. So that is the right way to go about it. Because again, this is the majority. This is the majority of the psychologists and the other mental health professionals who would refer to me. Because there are others who actually would say, Doctora, my psychologist diagnosed me with depression, but I want a second opinion. So there are some patients naman who do that. So again, just to set everything straight, for a diagnosis, it will be the doctor. The doctor does the diagnosis because the doctor is the one who will prescribe treatment. Yeah.
So doctor, okay. So psychiatrists and psychologists can work hand in hand, as can guidance counselors or whoever it is, any kind of counselor.
Correct. Yes.
Hand in hand.
Yeah.
But when it comes to the proper diagnosis, like you actually have depression and you actually have perhaps another mental illness or disorder or whatever it is, yes, it goes down to the doctor. And is that because depression is considered, is it a physical thing that happens as well? Is it not just, symptoms, or obviously feeling what we're feeling and symptoms which are already like serious and very detrimental to one's life, which is like not being able to connect with loved ones, not being able to function. But is it an actual physical thing? And what is that? Like what part of the brain is affected? Or can you explain a little more along those lines so that people understand?
Yeah. Unfortunately, we do not have a lab test that will say if this is abnormal, you have depression. We don't have that. Okay. Yeah. Depression, the diagnosis of depression is usually done through an evaluation, a psychiatric evaluation. It's through an interview, and there would some who would be philosopher and would say, what if I'm not telling you the truth? What if I'm just sponging it or something? The psychiatrist will know, because the psychiatrist will know what questions to ask you. And if there are inconsistencies in the statements, the psychiatrist will know about it and will be able to detect it. So that's the thing. So, but physical manifestations of depression, actually, there is pain. Sometimes that's why there is a specific antidepressant that they're marketing it for pain. Because, sometimes depression comes out physically like pain. But still, the disorder actually that is associated more with physical manifestations, physical symptoms, actually anxiety. Lump in the throat, palpitation, difficulty breathing, or being cold, clammy, and everything. Headaches, especially in anxiety. But as I would say in my lectures, they're like the terrible twins. when one is there, the others are just creeping around the corner. So anxiety, depression, usually they're like together. They're like the Siamese twins that you can't get rid of. That's the kind of thing. Yeah. But yes, depression can come out physically, through pain. Yeah.
And all right. So, and you did mention earlier when it comes to dispensing medication, of course, only a medical doctor can do that. So that would be a psychiatrist. So, maybe maybe we get a little bit to the. No, let's go into it now. We already mentioned it. Oh no, okay, a little bit later. I can't see this because I do have one question here that popped into my head.
Yeah. Okay.
You're saying only a medical doctor or a psychiatrist can diagnose depression. Like that is a proper
Well, a medical doctor. Sometimes your cardiologist will catch it. There because it's like this. Depression is so prevalent. That if you ask a psychiatrist, it's like the zombie apocalypse. They will come. You won't be able to. So we actually give out screening questions. The other professionals or the other internists, those other specialists they have. So they have screening questions for this. And if it's a yes, they actually say, okay, I think you might be depressed. Why don't you go to a psychiatrist so that, you really have a diagnosis that it's accurate and it's correct. The diagnosis is correct. Yeah. So medical professionals, they would be able to, but of course, when it comes to, because there are different kinds of depression, so so they go to a psychiatrist. Yeah.
Now I'm starting to think, I don't know if this is more of a question because I don't know if you'd like to answer it or maybe you can make a comment on it. But if you don't want to, you don't have to. But, there are cases, I'm talking about the law now and when you go into court and they ask, like, one side will have I guess the other person diagnosed with depression or whatever, and they haven't even examined the patient. Especially when I'm talking about annulments here in the Philippines. Okay, so one will say, oh, because the spouse of this one is this way and that way, and these people aren't even psychiatrists; they're psychologists. So, okay, because I would have asked you, why is the law that stupid? But then, of course, maybe you don't want to answer that. Maybe the one who drafted the family code that we now follow are the ones who should ask. But do you have a comment on that? Because if you do, please go ahead.
Okay. Again, I'll be politically correct again. Okay.
Yeah. Okay.
Yeah. So
It's one of us
like,
is.
yeah. So it's like this. We diagnose depression. I'll answer it by not answering it. Okay. Yeah. We diagnose depression by actually talking to the patient, talking to the person concerned. I cannot give a diagnosis just by another person telling me about the history. Why? Because the perception might be totally different. So I need to talk to the person before I give my diagnosis. There. Yeah.
Okay. There. Thank you, doctor. And that was for someone like 10 years ago. No. Okay. But yeah.
Yeah.
So,
because it's very unfair. It's like hearsay. It's like hearsay. Yeah.
see, like, okay. But I'm also bringing that because I know a lot of people have been through it. And it's just, to give a better idea really of what depression is, you can't just go about saying this or pointing to that, and I do remember a couple of weeks ago I had Dr. 𝗛𝗶𝗶𝗵𝗹 on, and I asked her, okay, how do you define or diagnose insanity? And she said, that's only really, insanity is only really, it's the law, so I'm like, okay, good. So then, and this popped into my head about, well, why are they saying people are depressed and giving all these, they don't even get to interview them. And it's
correct. Not yes. Yeah. No. So it, and it's loosely thrown around. You would hear teenagers would say, I'm bipolar,
yes.
I'm depressed, so those kinds of things. So it's loosely thrown around. Yeah.
Yes, it is. It is very much so loosely thrown around. But you were saying earlier, no, you put out a questionnaire and a checklist, maybe a questionnaire for other medical professionals like fellow doctors, like cardiologists,
Mhm.
And they do ask these questions, and they can flag it. And I'm sure just from being, I mean, yourself, from being a psychiatrist, just because you specialize in psychiatry, it doesn't mean that, when you hear of something or you see something, it doesn't mean you can't respond to somebody in an emergency situation and actually stop the blood, and if we were to think of a dramatic scene like that, or give someone how do you say this, CPR or something like that. So yeah, they can probably catch it, especially knowing the patient's history. So that way they might refer the patient to you, or tell them
Yeah.
you should see.
Yes. Usually they text me, Charm, I have a referral for you. Can you please see this patient ASAP? So yeah. So that happens. Yes.
I'm not a doctor, but I have many referrals. Okay. All right. So, we're talking. Okay. So we've talked about how it's diagnosed, and you said, okay, there's not one blood test, that tells us that this or that is not happening. That actually, that you're saying, that kind of concerns me, because I heard a long time ago that somebody took a blood test, this and she was then put on lithium because of the results of that blood test. Like, so how could that be possible if there's not, if is there a chemical, are there other, I guess the question there is, are there other tests, like for example blood tests, that can tell you whether one or maybe lacks hormones or has too many hormones of this kind? That, because one of the reasons you gave for experiencing depression is, let's say with females, in our hormonal cycles. Because are there tests that you can be, that other blood tests or other types of physical, I mean, tests based on physical or chemical.
I think I can see where you're going. Yeah. This is the thing. When the doctor is suspecting it's a depression caused by a medical condition, then yes. Okay. Most specifically, or most commonly, it will be the thyroid. The thyroid, yeah, because it controls your metabolism. If it's going too high, so it's mostly like mania. You're irritable, you're restless, you feel that you can't stop moving, you're kind of talkative. That's the irritability of a mania. When your thyroid is over functioning. But it's not only that. It's not only psychiatric. You will have other physical symptoms. Of course, blood pressure might increase, heart rate might increase, your breathing might increase. You could be flushed. So those kinds of things. There are certain other symptoms associated with it. When I say hypothyroid, the thyroid is not functioning. It's low functioning. So it could be associated with depression. So they don't want to move. They feel so slow. They feel so sluggish. They can't do their computations. They can't read. It feels like everything is so heavy. That could be part of a hypothyroid. But again, not only that. So heart rate might be too low, blood pressure might be too low. So there are other also physical symptoms associated with it. Another will be if a patient is on steroids. Steroids can either cause a depression, could either cause a mania. That's why we have what we call roid rage.
Yes,
sometimes yes, the kind of thing. So it's not enough that, of course, as psychiatrists, as doctors, you have to eliminate those medical possibilities, because if you think about it, those are the easiest to treat. You just take out the steroids, or you correct the thyroid, and everything's okay. Patient is not depressed or manic anymore. So it could be those conditions. Yeah.
Doctor, I have a question. When it's there are a lot of antihistamines that have steroids in them. For example, inhalers. Is that enough if you use it on a long-term basis to cause an imbalance in your body?
Okay, now that is an interesting question, because the question there is that one thing could be a trigger, or you could be using it for a long time and nothing's happening. So here what comes in is the X factor. Here is your body. So not all medications would affect all persons the same way. So the X factor is actually your genes. So that's why it somewhat explains, why is this medication good for her? And when I used it, it wasn't, that kind of thing. So it could be the genes. The X factor here is your body. So it could be not. Yeah.
Okay. Thank you, doctor. So, okay. are there different types of depression? I mean, there's minor, major depression, that kind of.
Before that was a diagnosis. Right now we have what we call of course we have a major depression. That is a disorder. What we have, what we call dysthymia. Dysthymia, it's like a long-standing depression. It's like in Tagalog, it's called sinat.
Mhm.
It's like it's there. You don't feel okay, but at the same time, with effort, you're able to do certain things. You're able to go about your life, but it's just for the ordinary person, maybe it's like this. But the
Mhm.
effort that it takes for those that have this time, it's like this.
Yes.
It takes a certain more effort, more energy just to do all of those things. And then it's bad. Like, for example, if they are dysthymic, that's a low grade depression. And then, like, for example, a favorite pet died, they might go into a double depression. So they're depressed, and then they might go into a major depression. So those are the things that we look out for. So we have that. Others would have what we call endogenous depression. Endogenous depression is, I'm okay. My finances are stable. My family is doing okay. I'm doing okay. I don't have any enemies. My work is okay. I'm being praised by my boss. Not everything's actually going fine. I don't have debt. My credit cards are in place. My family is happy. I have kids. But why am I feeling depressed? It's like they don't know where it's coming from. So that is what we call endogenous depression. The
Can
other
you
part is
share?
endogenous.
Okay.
ENDO, yeah, endogenous, GENOUS, yeah, yeah. The counterpart of that is exogenous, or what we call, there is a trigger. Somebody
Okay.
died, or I lost my business. I got scammed. So there is a trigger, and then of course you would become depressed because of that. It's like it's difficult to adjust to it. It's difficult to adapt. It's difficult to accept what's going on. Of course, it will matter when it comes to treatment, because endogenous depression is actually difficult to treat because you don't know where it's coming from. At
Mhm.
least with the one with the trigger, so you address it, and then at a certain point they will be okay. So
Not
those
the
are the two
exogenous, the one with
types. Yeah.
the trigger that they got
Yes,
scammed.
exactly. You got there's a trauma that happened to you. There's a trigger. Yung isa kasi, there's no trigger. Everything's going well, but then you just suddenly feel depressed.
Yeah.
You don't know why. Yeah, so it's harder to treat. Yes.
And the dysthymia, I'm sorry, this,
Yeah.
um, when, I'd like to hear you say that again. For some people, it only takes this much effort to kind of like function and do
Yes.
things.
For normal people, it's like this. So okay, I wake up and then I go about and do my business. There might be some little stressors or some disappointment that's happened within the day, but hey, I'm cool. I'm okay. I'm able to do things. But for them, so difficult to get out of bed. But okay, I'm going to get out of bed. Okay. Now I have to go to the grocery. Okay, I'm going to go to the grocery. Now I got the grocery. Then I'm home. Okay, I'll rest for about an hour.
Yes.
I have to go to yeah. So it takes more effort for them. So if we're just like this, giving effort, for them, it's like that. And
Yeah.
then by the end of the day, they're just so tired.
Mhm.
It's like they used up all of their energy. So my analogy for that is actually they're like a car, and
Mhm.
then we're running. But for them, when we end the day, it's like we have one fourth left in the tank. For
Yes.
us, we have our me time and everything. But for them, it's like it's gone. They're just running on fumes. Yeah.
Yeah.
So it's like that.
Okay. I'm glad you elaborated on that a little bit more so that more people who are not exactly maybe experiencing depression or don't recognize, maybe those who are will recognize that part, or maybe for the loved ones, or those
Mm-hmm.
who love the person who's experiencing it, they kind of get it more now, because I know interpersonal relationships get affected a lot when somebody has depression. And um okay, why don't we go to like um medication finally, because we're talking about that. How do you usually medicate depression? I mean, you
Okay.
mentioned a few types and what causes them. Is the medication always the same or not? Can we start with like the main thing when you start medicating someone?
Okay, so when we're sure that it's a major depression only. It's not like a depressive episode inside the bipolar, because that's a whole different animal.
Maybe we take
But
that
if
separately. you can do this, and then the bipolar after. Because a lot of people throw that word around, and we need to understand that maybe just a little bit on a separate level.
We might need another session for that.
We
But
should have one. Okay.
I'll just give it
Yeah.
overview later. Okay. If we're sure that it's a major depressive disorder, the treatment will be antidepressants.
Okay.
It will always be antidepressants. So antidepressants, before we have the first generation, we have the second generation antidepressants. I think what is being given right now, most commonly and most popularly are the second generation, what we call the SSRIs, the serotonin selective reuptake inhibitors. Serotonin is a specific chemical in the brain that
Okay.
we found out, researchers have found out that when they autopsied the brains of depressed individuals, they found that the specific chemical is actually low. So that's why we don't have actual live, laboratories that we can do, because all of these findings actually are through autopsies. These are through the brains of, people who died and they are diagnosed to have depression. So what they found out that the specific chemical is actually low in the brain, but the time of their death, of a depressed patient's death. So that's why mostly almost all of the antidepressants are focused on serotonin, so it's that kind of thing. So later on, other chemicals would come in and everything. So, but what is mostly very common is what we call the SSRIs. Now, the thing is, with all antidepressants, even the newer antidepressants, it actually takes 2 weeks before it starts working. Start pa lang. Okay, before initiating that it's working, it takes 2 weeks. It has to build inside your body. That is what we found out when we did research, that it takes 2 weeks, and then after 2 weeks, that's the time that you start feeling okay. Okay, so imagine it's 2 weeks. It's kind of long, that kind of thing. Yeah. So then
It's very long.
yeah. Then for full treatment, for us to make sure that it's working, and because there are some patients who it works, there is a response, and then plateau, nothing. And then they have some symptoms. So with me, I'm not happy. I want my patient to be okay. So it's usually 6 weeks. So we follow them up for 6 weeks and see if they're really back again. They're functioning well and everything. So imagine, since starting treatment 6 weeks, so it's about a month and a half that you need to make sure that these patients are doing okay. It's a history. Before, in the 1970s, the only criteria is for them to respond to the medication, and then they will be okay. Okay, the medication's working, so we have a response already. In the 1980s, it wasn't just a response.
They given in the 1970s just for a patient.
This is the first generation antidepressants. We call it the tricyclic antidepressant. It's full of side effects, but it's very effective. Yun nga lang, the tricyclic antidepressants. Yeah.
Would you have handed it out as what brand name? Or is that you're not supposed to say that? I mean, but if it's
I don't know, because I don't think they exist anymore. Or if they exist here in the Philippines, only one. Yeah, but it's anafranil, those kinds of medications, Protiadin, those kinds of medications.
Okay.
It's not available anymore in our market. In the 1980s, it wasn't just a response; it's remission. Remission means the absence of symptoms. The depressive symptoms are gone. You would think that it's okay, but it's actually not. Because in the 1990s, it's not enough that we have remission. We want our patients to actually be functional. That they're able to take care of themselves. They're able to interact with family members. Usually it's like that. In the year 2000 and now beyond, it's not enough that they're functional. We want them, we want their functionality. We want them to be functionally active, that they are okay. It means that they're able to work, they have families, they're able to take care of themselves, they're able to be sufficient, to be self-sufficient. So as you can see, even our definition of how a patient recovers, it's evolving throughout the years.
Yes.
Actually, it's decades. Yeah, it's through the decades. It's evolving. So I would really like the definition right now, which is what we call functional recovery. The patient actually really recovers and becomes a productive member of society. So that's what we want. Yeah.
Great. That's okay. That's what you want, and that's what you aim for, and that's great. But when in treating a patient, I just you have to say, like, do you also go through the stages, and what does kind of patient expect? Like, will they be, for example, in the 1970 stage where there's a response, I don't feel that bad anymore, and
Yeah,
then
but I'm very sleepy. I'm so sluggish. My weight, I'm gaining weight. You know,
yeah,
those kinds
then
of things. Yes.
before it gets to that, because it's great that for depressed people or people with anxiety or whatever it is, it's great to get back and to be on top, but then they're need to be on top or maybe back at the top of the game, or maybe felt in such a good way that they've never felt before. But is there also, like, how long can it take? Do they have to be patient with themselves? Do the people around them have to be patient? Because it's not just like that.
Yes.
When it comes to that.
Yeah. Actually, when I say that, it's like,
you gotta have to be super good again.
yes,
Within
exactly.
months,
You know, when usually that is the next question. Up until when will I take this medication? You know, treatment of depression, especially with the traditional oral antidepressants, actually will take up to 1 year. You know, 1 year that they have to take the medications, because that is, you know, in researches again, that is the time frame where we found that all of the chemicals will balance out each other. It really actually takes about a year for everything. Why? Because if you stop, and this is usual, you know, when you feel okay, you stop meds, and then, hey, I'm okay, you know, and then here it comes again, it will rebound, and then it will be harder to treat. So what I tell them is that when you stop medications, and then you know, you're getting better, you feel better because of the medications, not in spite of the medication. So that's what I tell them. So very important that you continue, because the chances of relapse, if you finish the 1 year, it's about 80% down. You know, it's only 20%. But if you don't finish, it's around 80%. So imagine, we're just fighting for 60% here. So that's what I tell them. But hopefully it sticks. But sometimes it's like, no, doc, I just wanted to challenge you. I stopped it there. So here we are again. And there are patients are like that. And they would tell me, you know, tama po pala kayo, doktora, pag hininto yung meds.
And then,
this is what will happen.
Guess what, doctor? We're back to zero.
Exactly. Yeah. So for other treatments of depression, we have something that's actually very new, and this is the first in the Philippines. 𝗛𝗏 is actually the first that will offer this. And the two main indications for this is what we call the treatment-resistant depression. You know, it's like the depression that really doesn't want to get to leave, even if you
prescribe.
Yeah. After about two different classes of antidepressants, you have your SSRI, maybe you have your serotonin or epinephrine, you know, another category of an antidepressant. You have two adequate treatments, like, for example, up to 8 weeks maybe or something, and you can see the depression is not remitting, it's not going down, it's actually getting worse, you know. So we actually have this treatment. It's called esketamine. You know, that is one indication. Another indication is actually what we call major depression disorder, major depressive disorder with imminent suicidal ideations. Imminent suicidal ideation means that they cannot wait for 2 weeks before, you know, because it's already there, you know. So imagine that, you know. So we actually have treatments for those two kinds of conditions. Yes.
Doctor, we just need to take a short break, but because I would really want to discuss, apart from the, you know, how long things can last and other things in between, the new medicine and new medication, the new treatment, which is esketamine, right when we get back from this short break. So guys, stay tuned. Very exciting part. Yes, I'm leaving you on a cliffhanger. We stay tuned to Healthline with Makati Med. We're here with Dr. Charm Bernardo, and I'm your host, Nicole Jacinto. We'll be right back.
You're listening to DZRJ 810 AM. We'll be right back after these reminders.
Hi, this is Dr. Jacinto from Makati Medical Center, and I'm happy to share that our world-class quality healthcare with the heart is now more accessible and affordable at Makati Med Care Access, Araneta City. What's more, Makati Med Care Access is the only single-use hemodialysis center in Araneta City. It's now easier for patients to avail of renal care services right in the heart of Cubao. We offer health screening and diagnostic procedures in this facility at affordable rates. You can get services such as mammogram, ultrasound, lab procedures, ECG, and many others. We believe that access to affordable, quality, and compassionate healthcare is a basic human right. And we at Makati Med Care Access Araneta City are doing our best to make this possible to more people. You can find us at the ground floor of Manhattan Plaza Tower 1 in Araneta Center, Cubao. We are open from Mondays to Saturdays from 7 a.m. to 5 p.m. and Sundays from 7 a.m. to 4 p.m. For inquiries, you may reach out to us at the numbers below. We look forward to serving you here at Makati Med Care Access, Araneta City.
You're back with Healthline, keeping you healthy, moderated by Nicole Jacinto.
Welcome back to Healthline with Makati Med. Okay, I got the giggles. I'm here with Dr. Charm Bernardo, and it's ironic that you have such no, it's not ironic. It's actually a gift that you have this presence. I've met you in person, and even online. You have this presence and a face that really makes people want to smile, and I think that's the best kind of difference for a psychiatrist, really.
Yeah, well, I've also done some interviews, and my friends, my barkada would actually tell me, "Hey, come on, why are you smiling? You're talking about depression and suicide." And it's like, I can't help it. I like the topic, so so there you go. I am so sorry.
No, you don't have to be sorry. I mean, I think that there is humor in many things, and that smiling, a lot of people who smile may be depressed and maybe suicidal. Mm-hmm. And so, and then a lot of people who look more serious, or they may be actually more stable. So it's, we never really judge things that way. And it makes all the more for, you have an engaging dialogue style. So I'm sure more people will actually listen and get the message that you're sending, that there and all there is to learn from you, the message that you're sending out to them, and all there is to learn from you. So, okay, before we took a break, we're talking about some medications that are for long-term, resistant, not for
treatment-resistant depression.
Resistant depression. And long-term depression later, but let's talk about esketamine, which was mentioned. All right, can we talk a little bit about that? You were saying, for some people, and is it just for depression? Okay, let's say it's the first time someone said, can this be used the first time? I know it's for treatment resistant, but has anyone ever used this for the first time? My second question preceded my first. What is esketamine, doctor? Okay.
Okay, maybe we go into that first.
Yeah.
Okay. If the traditional antidepressants would utilize three chemicals in their brain, we call it the triamines. You have your dopamine, which is your pleasure chemical. When something good happens to you, that is the chemical that comes out. That is also seen to be decreased in depression. One is norepinephrine. It's just adrenaline that gives you the adrenaline rush. That's also decreased in depression. And the third, as I mentioned a while ago, is actually serotonin. So almost all, I think all antidepressants, except esketamine, actually utilizes those three chemicals. They really just bombard you with that. But with esketamine, it actually utilizes a different pathway. It doesn't make use of those three chemicals. It actually utilizes a different pathway of the brain, and it involves a chemical that's actually the major excitatory. It excites the brain. That is what it affects. That is esketamine. So what happens here is that if traditional medications, you take it by mouth, esketamine is given through the nose.
Yes.
Okay, so it's intranasal. Yeah. So usually you have two nostrils, so you give it intranasally. So why is it this way? In a way, if you think about it, our nose is very, what we call, there are a lot of blood vessels in the nose. That's why if there is, if somebody just bumps into your nose, it will bleed. Because there are a lot of blood vessels. It utilizes, very rich. So esketamine actually utilizes those blood vessels. So once you put it in, goes to the blood vessels, of course, direct to the brain. Mm-hmm. So it acts quickly, And some people would say, how quick? It's actually as quick as 2 hours. So 2 hours after administration, your depressive symptoms actually go down to 0. So patient has no depressive symptoms. Their face is actually lighting up. So that is the idea of esketamine. So what happens there is that, of course, it's not like a testimonial. Of course, we have rating scales in place, rating scales for depression. At the start, before administration of the medications, we have all of these questions regarding depression, and the patient will answer them. Mm-hmm. And then as time goes by, we periodically would administer the scale, and we could actually see the numbers going down. So for example, if the score of the patient at the start is a 20, 20 means moderate depression. Patient has problems sleeping, is not eating, has problem concentrating, maybe some thoughts of death there, doesn't want to live anymore, feeling depressed, no interest in doing whatever he wants. By the time 2 hours are over, that score from 20 becomes 0. So patient is okay, feels lighter, feels good, that kind of thing. Yeah, so that's how fast it will act. So that is actually the difference between waiting for 2 weeks and just 2 hours. But if you think about it, between 2 hours and 2 weeks, a lot of things can happen. A lot of terrible things can happen. Yeah. So that is the thing that we want to avoid, something bad happening. So imagine if pardon me?
2 hours is actually a long time for someone who feels so bad. Even.
Yes. Correct. So
a lot of bad things can happen. Go ahead.
Yeah, so a lot of bad things can happen. So imagine 2 hours. And as we know, suicide or the thoughts of suicide is actually a psychiatric emergency. So when a patient is suicidal or have those thoughts, immediately I would ask a patient to go to the emergency room immediately, because safety now is a concern. So when a patient is there, of course, we have to admit the patient. Admit yan, and it will last for some time because we give the antidepressants, we wait for it to be okay, we wait, and that kind of thing. But here, actually, we just had the patient, we were able to do it 2 hours and the patient goes home. So this is outpatient. Again, when by the time 2 hours are up, the score is 0. And no thoughts of wanting to hurt himself. No thoughts. It feels lighter. The only thing that he said is like, doctor, it felt like I went through a very difficult exam, but now I'm very hungry. So imagine, because depression, he wasn't eating. There was no appetite. Now it's back, and again, the depressed mood is gone. Most importantly, the suicidal thoughts are gone. So in 2 hours, the medication will be able to do that. Yeah.
Okay. Now I have a lot of questions about not just only esketamine, but like maybe start with the traditional medication first. In a sense, just to define like some things for us non-medical professionals and people, for you to give us a big and clear picture. Dopamine, norepinephrine, and serotonin.
Serotonin, yeah.
Serotonin. Okay, so now these chemicals are found in the brain. As you said, dopamine is the pleasure chemical. Okay,
yes.
And norepinephrine is that adrenaline rush, that high that we feel. Okay, and then
yes,
that's why sometimes there are certain things also, like when you exercise. Afterwards there's something that's released, no? So I mean,
it's dopamine. That's dopamine. Yeah.
So that can sometimes, when you ask patients with depression to do a little more physical things, and I mean it can help, no? There's so many ways to treat it. That's one of them. And
I need to comment on that later. Remind me. Yeah.
Yes. Okay. Okay. My God, can you remind me to remind you? Wait. Okay. All right. Somebody remind Nicole to comment, to remind Dr. Bernardo to comment
regarding the exercise and the physical thing with patients with depression. Yeah.
Yeah, and some people can't because they're like they got injured, so like how do you, right? Then
Yeah.
that's dependent on the medication.
Well, I could answer it right now, that so that you don't need to be reminded. The thing is, we would hear doctors. I would hear the other specialists would say, "You exercise. That's okay. You can do that. You just walk." Because segueing a little bit, there
Yes,
is
go
a
ahead.
bidirectional relationship between diabetes and depression. They would say that diabetes can cause depression, and at the same time, depression can cause diabetes. So we found out that there is a bidirectional relationship. So usually, these doctors would say, just exercise, just walk and everything. So the patients actually would come to me and feeling bad. Why? Because they would tell me, Doctor, I really know naman that I need to exercise. I know that I need to walk, except that it's very difficult initiating things. And
Yes,
that is the problem with depression. It's
that
very
is what
difficult to
I'm talking
initiate
about.
things.
It
Yeah.
is, right?
Yes. Yeah. So
Wait,
they know what to do. They know what's good. It's just that they can't do it so hard. So it's
yeah.
easier said than done. Yeah.
Yes. And we'd
Mhm.
like to, of course, share that with some other people out there who also just like, yeah, easier said than done. But of course, it's advice well taken. But as so many of these things are easier said than done, so it's not like,
Mhm.
oh, you can just walk all of your depression away, or you can just, I mean, good if you can, but if you cannot,
Yeah.
don't
It
come back.
doesn't work that way. Yeah. Yeah. It doesn't
Or you
work
can
that
try act
way.
on your depression away, but it doesn't always work that way.
Mhm.
Okay, so
Correct. Yeah.
a lot of the first, second generation medications you're talking about, they address these, like, for example, one will help the release of dopamine. The other will also, let's say, help the release or cause something in the brain to release more norepinephrine. And the SSRIs there, uh they stop another chemical from putting down the serotonin, so that your brain can reuptake it, right? So
Yeah, there's some the medications who are like that. But the premise of all of this, almost all of these medications, that it's the concentration is with those three chemicals.
yes, okay.
Yeah,
When it
yeah,
comes to you, so okay, so at least we have that there. When it comes to esketamine, you said it acts on a totally different chemical.
yes, yeah. That chemical, it's glutamate. It's a totally different, and glutamate is the major excitatory, chemical in the brain. It activates a lot of things. That's why if there is too much activation, it's also not good.
Also not good.
Yeah. So but the thing is, it that your ketamine actually modulates all of this activation. So imagine if you already have an antidepressant working on those three chemicals, and then you have ketamine working on the major excitatory chemical in the brain. So yeah, so maybe, I'm not saying, but maybe it contributes to why it acts so fast.
Okay.
It's a yeah. So that is one way that ketamine is actually also working. Yes.
So with depression that is resistant to treatment, or we'll put, as we put it,
Mm-hmm.
do not stop the medications, the other
Yeah,
medications.
we don't. Yes.
Add the
Yeah.
dose of
Yes. We
esketamine.
add, yeah, together with major depression. We don't stop the antidepressant. We add it. And then, boom, we see very good results. Yes.
And esketamine is only given in a clinical setting.
It can only be purchased through the hospital. So that's why, we have a care center. Again, I'm actually very proud of it. It's the first in the Philippines that we have this. I was actually gunning for the first in Southeast Asia. Unfortunately, Singapore got ahead of me. So, but it's okay. It's still in the Philippines.
It's Singapore.
Yeah. Yeah, exactly. So here they actually, well, the maker of the Medicaid actually trained us, but at the same time I also had training. So I actually abroad, it was already being used there, but an IV form, and it's ketamine that was being used. Here they modified it so it's intranasal. So it can only be purchased through the hospital. It is given at the time of the purchase, and for those 2 hours, my psychiatry resident and a psychiatric nurse doesn't leave the bed, or the where the patient is having the esketamine treatment. So the monitoring is continuous for those 2 hours. We have to make sure that they are okay. Yeah, usually the side effect of the esketamine would be increase in blood pressure, and what we call dissociative symptoms. Dissociative symptoms is like you're out of your body, and then you're seeing yourself being administered, or that kind of thing. It's a feeling of being unreal. Sometimes you feel a little dizzy, or maybe a little sedated, but after 2 hours, all of it goes back to normal. So it's very transient. It's just, it's just going with the peak of the medication, and then after 2 hours, the medication is out of the system, so everything goes back to normal. Yeah.
Okay. I'd like to delve into this a little more because I know some people will have questions, or when they, if and should they start looking it up. So esketamine is basically a small dose of ketamine, no? Or some type of
no,
ketamine.
it's not a small dose but it's a derivative of your ketamine. Yes.
And ketamine, in its history, is it was a drug that was manufactured in the 60s, maybe early
Yes.
60s.
It's an anesthetic. It was given as an anesthetic. Yeah.
It was given as an anesthetic, but it's hallucinogen as well. It has hallucinogenic
Properties.
Properties.
Yeah, properties. Yes.
They used it a lot during, say, the Vietnam War. For surgery and all of that. Just as they used LSD and all of that. So it's not. It has hallucinogenic properties, but it's not. The ketamine is an anesthetic until now, right? They still use it as an anesthetic.
Yes. So, mostly, I don't think for humans anymore, but for veterinarians, that's the anesthetic that they use. Now, that's the thing. That's why the drug company actually developed esketamine. So what we see as side effects is actually very, very light. It's very, very, minimal as compared to the actual ketamine.
Yes.
Yeah.
I mean, it's been abused before. It's not an illegal substance, but taking it or abusing it in a way is what is illegal or detrimental to one's health. Just like any drug, actually, even if it's, I mean, even
that's
if you
why that's why esketamine is only available. Esketamine is only available through the hospital. You can't buy it in Mercury Drug or Watson's or everything, and the doses are limited. It's a special device, and again, the healthcare professional is there to make sure that that everything's okay. You're monitored throughout. Yeah.
I wanted to bring that up already and highlight it because I also personally feel like too many drugs are given a bad rep, a bad rep and a bad rap.
Yeah.
Too strict on all these things, but yet we have everything else out there that can hurt us.
Correct. Yes, I agree with you. Yeah.
I mean,
so this is actually a very exciting option, because for me, the how fast it acts. It really carries for me a lot of weight because that is a concern. Of course, I don't want my patient to do something to him detrimental to him or herself. So the sooner that I can eliminate it, the better it will be for me.
Let me be the one to say it, and so it's not you. Like if a person is really depressed, they can go out and maybe harm themselves or commit suicide. I mean the suicide will be like successful, or I mean, who knows what could happen, not really meaning to, but being depressed, they could add on to what they're taking. I mean, it could be an accidental thing, or they could then add the alcohol to the mix and then get it on accident, not really care, because at that moment they're just simply not in the right frame of mind. Someone could hurt them, they could hurt someone else. I mean, whatever, unintentionally. It's usually a person who's depressed will end up getting hurt and not being and not be the one to hurt, someone, unless, I don't know, you drive them off the edge. But it's really, so that's what you're saying but not saying, because let it not come from your mouth that here thinks it's suicide. It can help really prevent that, because 2 weeks is a long time for some rest to for them to feel better. And this acts in 2 hours. I mean, I guess you imagine a very, very hungry person whose blood sugar is dropping and is down. and like they can't even eat anymore because it's so low and they're about to go into a coma. That's how overwhelming something can be.
Correct. Yes.
Horror and just I'm done, and
And that's the only way out.
yeah.
That's the only way out. So for you to be able to do something, for us to be able to do something about it quickly,
Mhm.
and that for me, that's very significant. Very, very, very significant. Yeah.
And is this how new is this ketamine?
Well, I think it was introduced in the market, I think just last year.
Just last year, okay.
Yeah.
And first in the
Yes.
Western markets or in the USA or
No, in the USA they have it already. They have been administering it and everything.
okay.
So actually they didn't need to go through all of our regulatory processes here. We didn't have to do a trial and everything, a clinical trial, because it already has been approved. In other countries and here they saw that the evidence is so robust when it comes to esketamine helping our patients. So it was already approved. Yeah.
So in like if you feel it's necessary for a patient to get this to get esketamine, or what would make someone a candidate like let's say an ideal patient or candidate, what would qualify them to get esketamine, a treatment in your clinical setting under
Yeah.
supervision? Yeah. How would
Yes.
you determine if it's if this patient should probably take this or is okay for this?
Yeah. Well, usually these patients, they have their own psychiatrist. So that's why, I talk to them and give lectures to let them know that we have this option for their patients. So they talk and then they say, look, we have tried this and this and this and this and nothing's working. Maybe patients and actually would have gone through electroconvulsive therapy, ECT. Yeah, they have already done it and still nothing worked. They're still very depressed. So we have a new treatment. So why don't you try this out? Yeah. So that is treatment resistant depression. Another is, look, hey, you're kind of suicidal right now, So yeah, why? Why
Yeah.
don't you go to the emergency room? And from the emergency room, let's set it up and then immediately let's give the ketamine already. So
Yeah.
it could be those two indications for now. Okay, for now. But
For
I'm
now.
sure there are other studies that are being done that might be open to other indications. But for right now, all over, those are the two major indications.
Indications. And you've never found a case for it to be where like, oh, this is your first time being depressed, but it seems to be like, like you've never been medicated, and we think you're depressed because some people will not show anything. They don't get the chance to be
Yeah.
medicated. Talk to a psychologist or psychiatrist, and then the first time anyone takes notice is an attempt on their life or something like that, on their own life.
Now yes, candidate for esketamine could be a very good candidate for esketamine. Imminent suicidal ideation. Yeah. Mhm.
Yeah. And then, okay, so, just clearing things. You know how my imagination, this doctor can think of all the possible things at once.
Yeah.
I have ADD. Maybe you could diagnose me. Yeah, you have ADD. Everything else.
We need to talk. We need to talk first.
Yeah. Okay. So, yeah, I mean, definitely there were a lot of people who I come across so many people in life. So, it adds to what I can ask you. I mean, and it's just great. There's so much synergy for me. I'm passionate about getting more, knowing more about medical things and health things. And I may not always be passionate about my own health, like exercising and all that, but a lot of it just happens. So I can just think of so many things, and this I can always refer. I'm like the great referral person. Oh, do you know, doctor? Yes. Just call up this place and that. But depression is something that really I also, I think a lot of people, there's not such a big stigma around it anymore as much as there used to be, or
Correct. Yes.
other
Correct.
health issues. And do you think what do you think brought that on? Is it the positive imaging, or did the pandemic have anything to do with that, when people simply had to admit that things
I think you can see my face. Yeah. I think the pandemic had a lot to do with it. Why? It's no. This is my own personal experience.
Yes.
Okay. Before the pandemic, my waiting time usually in the clinic is about 3 weeks to about a month. So that's the time, and then I would be able to see my patient. Of course, pandemic came, everything closed down. The first doctors, I think, one of the first that then actually adjusted to the pandemic is actually the psychiatrist. Because
Yes.
the psychiatrist, we didn't need to touch the patient, so we can do it online. So I think one of the first specialties to adjust would be the psychiatrist. At the time, people are actually concerned. They're concentrated on their survival.
Yes.
How am I going to deal with this? What hand washing? Whatever. Ultraviolet. Those kinds of things. So everybody was so focused on their own survival. So as the pandemic went by and people adjusted to it, now there are certain things that come. Usually it's food. Oh my God, I lost my job. Oh my God, my job is different now. I think I need to learn a new skill, that kind of thing. Okay, the kids are here. They're doing online. I need to work. So there's a lot of adjustments were happening. But at that point, people were adjusting. They were adjusting well. And then I think Delta hit. And this was the bad one. There were a lot of deaths. Even the dad of your friend, someone you knew was
Yes.
dying. The death. Yeah. So there was this. So of course everybody was in survival mode, but still we were able to adjust. After Delta
Families
passed,
were wiped out. Like whole households were wiped
Correct.
out by.
correct, yeah. So it added, oh my God, my parents are not here anymore and they take care of the kids while I'm busy working. So how am I going? So there are a lot of adjustments going on. But the thing is, in those 2 years of the pandemic, our world became small. It
Yes.
was that, that was it. We adjusted to that. By early 2021, things were opening up again.
Mhm.
And then people realized, oh my God, it's not shutting down. Unlike before, we would open and shut, open and shut. But here it's opening and it's opening and it's opening. Then
Yeah.
people had problems adjusting to the new thing right
Yeah.
now. Why? Because it's not as simple as it's just like before, then it will be okay again. No, because now we have a new variable, which is the virus. So for elderlies, before I could do my Tai Chi in Luneta, but now I'm already diagnosed with diabetes. What if I get the virus and die? So there are a lot. Before, I can just go to work, but now my parents are dead. So who will take care of the kids? My business failed. So it's so difficult I don't have the energy anymore, or maybe the finances anymore to build it up. So yes, it's opening up, but now people are faced with new challenges, and it seems it's more difficult to adjust now. So going into that, and for me, my clinic, it started October 2021. My wait time from about 3 weeks to 1 month actually became 3 months. So
Wow.
I think, yes. So I think all psychiatrists, it's like we are experiencing our own personal zombie apocalypse.
Yeah. Yeah, I know. Because the thing is,
Yeah.
you want to get back to your patients right away, but
Correct.
you
Yes,
have
and yes, and now, survival mode is over. We have food. I know how to, now it's time for me to take care of my mental health.
I
So
don't.
now all of this is coming out. Yes. So there is a progression to it. So now we're seeing. So I think the stigma is lessened, but by necessity. It was forced to them by the pandemic. You need to take care of yourself. There's a lot of realization. Yeah. So that's, I think, what happened.
And
Or what is happening. Yeah.
as a patient or outside observer of what doctors go through, there's so many medicines now that are always out of stock.
Yeah. Oh, yes. Oh,
Yeah,
yes. Yeah.
drug companies. Sorry, not drug companies. Drug medicine retailers, get your act together. Because I happen to know that you guys are also trying to do the purchasing on your own, and whatever the heck it is. Please, the doctors are. I mean, do you get calls like that? Like, oh my God, the medicine is out of stock.
Yes, January to March, it was my own personal apocalypse also. It's a particular,
Yeah.
I don't know if you're familiar with Ribotril. It's a muscle relaxant,
Yes.
and it's for anti-anxiety.
Familiar with a lot of medicines, even though I haven't.
Yeah, it was like gone from January to March. So
Wow.
it was it's not
Oh,
it's
I
for
knew
the
that.
entire Philippines. It's
Yes.
for the entire Philippines. So I actually have patients actually going back to Bacolod, they just to buy medicine there. Or
Mm.
one patient actually bought medicine in Baguio. It was
Yeah.
that bad during the time, that those from January to March. So of course, if you run out of medicine, I need to prescribe a substitute because
Yes.
we 12 o'clock in the midnight, 1 a.m. in the morning. Doctor, there's no
Yeah.
the name. Yeah, so
Yeah.
I
I know
need to
that I
prescribe.
actually know that medication. Yes. And I
Yes.
don't worry, doctor. I know a lot of types of
Yeah.
medication, whether or
Yeah.
not I
But
will.
yeah, but the problem is, of course, we prescribe the substitute. It's not only me prescribing the substitute, everything.
The
So they
substitute
say,
is also gone. Yeah, I
oh my
don't.
God, doctor, there's no more value.
I remember I remember I talked to one of my doctors and I was like, by the way, this medication you prescribed, it's out of stock. And she's like, well, I'm not gonna prescribe this substitute because but my other patients were saying that it's also out of stock. I'm like, oh,
Also,
okay,
yeah.
yeah. So, yeah. So
It was bad, and I was like, can I go on a leave right now? It's like,
and it's one of the most difficult specialties to go on leave from.
yes, yeah,
Yeah. You gotta have good friends, other
yes,
sites
yeah.
who
Yeah, you need to, and you need to know that they will have your back when
yeah,
you go for, and you can't go for long
you
because
can't.
it's a problem when you come back. Yeah, so
And your holidays are you
yeah,
don't get holidays because holidays are days when depression kind of hits you more.
yes.
And other,
Actually, I'm also a toxicologist, so I deal with poisonings and overdoses and everything. So actually have two
okay,
peaks wherein they commit or they attempt suicide through overdose. One would be the holidays. You know
mm.
why? Everybody's happy. Why I'm not happy? So I feel depressed.
Because
You can
they're
actually
happy but they're drunk. It's okay. Don't kill yourself. Okay, sorry.
I
That's
know. Yeah. So it's during that time, approaching the 25th and then a little bit more days after the 25th. Yeah. So it's a peak. Another peak will be Lenten season. And it's not because of, I'm so guilty, no. It's
yeah.
because of the grades.
The
Because it's that
grade.
time that the grades are being given out. And
Yeah,
those that are failing, not telling their parents yet. So
yeah.
so those are the two peaks, that I've observed,
And maybe it's also like all the what I noticed from my own, just my personal experiences. I always, when I was younger, it's like I understand why people would be sad on holidays in terms of losing, certain family members and all of that. But then I always could somehow find a reason to rally around it until the day in my 30s when I finally said at one point something that I never thought I would say. I hate Christmas. Like, I understood why the people older than me, I would sometimes hear them say that stuff. And then I was like,
yeah.
you know what, I'm gonna love Christmas again. Okay. And then
Mm.
a few years back and up to now, I'm like kind of there's just too much interpersonal dealings and conflict that arises out of
Yes, because
know,
that's the time of reunions,
yeah.
and it's kind of stressful. It's a happy time, but it's also very stressful. So I actually advise my patients, hey, why don't you go out? Go to Palawan, go to Boracay, go out for that particular span of time by yourself.
Yeah.
Yeah, so that's what I say. Go out so that you're not going to be stressed out. Because if the patient is stressed out, then I will be stressed out. They will be calling me, they'll be at the ER. Go,
Yes.
go. Yeah.
Yes. Go. And by the way, come back if you need that. Come back to Makati Med immediate. Yeah, I can imagine that would be the time for you. And I'm must be pretty bad for you considering what I've done to doctors over the holidays myself. No, okay. So, doctor, okay, getting back to the topic, no. I mean, if someone doesn't treat depression aside from suicide and okay, let's we know that's it. Aside from suicide, um, which is like the worst possible thing that could happen, and having, let's say, there are there in their interpersonal relationships damage, which could even lead to more depression because people don't understand why you're down, why you're feeling this way. Has to be explained to them also, or they think maybe, you're not making enough of an effort for them. What or why are you like that? You keep, it's a theme that keeps recurring when someone's depressed. Parang a lot of people first get the impression, tamad ka kasi eh. Do you get that a lot?
Yeah.
I mean, tamad ka kasi.
Mind over matter. Mind over matter lang yan. Yeah.
Just, nasa ulo mo lang yan. Oo nga, nasa ulo ko. Tama ka, pero not in the way you think.
Correct. Yes.
Like, tamad ka kasi, or hindi, ganyan ka talaga. Gusto mo matigas kasi yung ulo mo, but it's not it, right? No?
Labanan mo. Yeah, that's so common. Yes.
So of course, there's a component to the person who's depressed trying to fighting to survive it or overcome it, or even be on top in spite of it. But sometimes other people can't get that.
Yes.
That is, they are giving their best.
Yes.
At least the people who aren't faking it. And as you said earlier, a lot of psychiatrists will be able to tell if you're faking it. I mean, I always dealing with smart doctors because I don't want to be able to fool them. I try to run circles around my doctor for the first, any doctor for the first, like, I am admitting this to any doctor out there for the first, 10, 15 minutes. And if I don't think I'm just like, just go with another doctor. Sorry, but I do that. So if I tell you, doc, you're good. I mean, that's I'm being sincere. Any kind of doctor, like, there's many good ones. How can I accept the ones that, are not that great? But anyway, back to the topic. What are the other, so apart from all these emotional and psychological things that are already so difficult, how can it affect a patient physically? Like, aside from suicide and hurting yourself and all of that.
Of course. Imagine the loss of productivity. You're not, and imagine you not living up to your own potential. Imagine you. If you think about it, it's like wasting away. You yourself, you're wasting away. So not for anybody else, not for but for you. I think you owe it to yourself to help yourself, to be the best version of yourself. So when you are depressed, yes, I'm depressed, okay? But the first step there, and the first step, and it is a strength and not a weakness, is actually to seek help, because you yourself won't be able to. So ask the help of a professional. The professionals there would be able to help you achieve the best version of yourself. So if you don't treat your depression, you're actually, being unfair to yourself. You're not giving yourself a chance to be the best of what you can do. Yeah, imagine the wasted potential of you. Yeah.
I'm glad you said you owe it to yourself, doctor, because a lot of us have heard you're wasting your potential. Actually, I've heard that a lot, but it's more of an accusation than you're wasting your potential. But I'm like, okay. Yeah. But I'm glad you said you owe it to yourself, no? Not just because to some idea that we all have to be productive, working hard.
Not to some expectation of you.
Yes.
Yes. Yeah.
I've heard that accusatory tone from other people, but I'll just, I'll wait for myself to accuse myself of not really. What other advice, doctor, or anything you'd like to advice you have for people who have depression, or people who are maybe taking care of, or who love people who are depressed? And, just as parting words, because apparently I've just been informed we're running out of time. Why do you always do this when I'm having fun? No, okay, go ahead, doctor.
Okay, what I want to say is that for all, there is hope. Okay? And there's always people who will be supportive of you, people that will help you. So, as in Tagalog, habang may buhay, may pag-asa. So you owe it to yourself, to see what's out there, to grow, to develop, to be able to know who you are, what are your likes and what are your dislikes. So I think you owe that to yourself. So please, if you're feeling like this, always there is a professional that will be able to help you. And that professional, I guarantee you 100% will be very supportive of you.
Thank you, doctor. And to add on to what you said, syempre naki-add on pa, pero ganyan talaga ako. Habang may buhay, may pag-asa, because there's always someone who cares about you, laging
Yes.
mag-alala sa'yo, or who cares.
Mhm.
It doesn't have to be the person closest to you. And don't get hurt, kasi it might be...
Yeah, that person is actually you. You have to love. That's called self-love. You have to love yourself. Yeah.
And for those who I've heard so many people like, no, because my whole family hates me. It doesn't have to be your family. It doesn't have to be your boyfriend, girlfriend, lover, husband, whatever.
Correct.
Wife, eighth concubine, boy toy, whatever it is, It doesn't have to be that person. As you said, can be a mental health professional. It's not just because they're getting paid. You wouldn't, it could be just a stranger.
Yeah.
Sit down with you for 5 minutes and give you an kindness. So, yan, tama si Dr. Bernardo. There's always someone who cares. There's hope. Thank you, doctor. I'm gonna ask for your number after the show. And that's just to keep in touch. Don't worry.
Sure, no problem.
Okay. All right. So, folks, that's all for to this episode on Healthline with Makati Med. Thank you, Dr. Bernardo, for being with me on the show again. And I hope to see you not in a clinical setting, but but I don't know, somehow
in a social setting.
Social setting. For social anxiety, that could be a whole
that's another topic.
Another topic. All right. So folks, Healthline with Makati Med, and then stay tuned for the next program. See you again. Bye.
Thank you.
Thank you for tuning in to Healthline with expert doctors from Makati Med, giving you the chance to interact, uplifting your lifestyle. Moderated by Nicole Jacinto. Tune in again next week for your weekly dose of Healthline.
The views and